Hello and welcome to another short video of the 12-lead ECG I've Got the Rhythm Facebook group. In this episode we will be looking at some case studies that have been previously posted to the group and using them to discuss and explore De Winter's T waves. What then are De Winter T waves? These were first described by Dr. Robert De Winter in 2008 and published in the New England Journal of Medicine. This T-wave pattern was found in case studies that showed around 2% of patients with an LAD occlusion had this on their ECG. These results were repeated in 2009 by Dr. N.J. Varuden and have been proposed as a STEMI equivalent by some, including the American Heart Association in 2010. The De Winter T-wave is diagnosed by finding upsloping ST depression of more than 1 mm in the precordial leads, tall, peaked symmetrical T waves in the precordial leads, and slight ST elevation in lead AVR of around 0.5 to 1 mm. Credit for this case study goes to Alex Beckett, and this ECG is from a 43-year-old male with onset of central chest pain whilst out running. The patient presented with shortness of breath, vomiting, pallor, diaphoresis, which is the posh word for sweating, and agitated. So what can we see in this ECG? Well, if we start with a systematic approach, the rate is around 60 and the rhythm is slightly irregular. The axis is rightward and the computer measurement gives that at 105 degrees. There are P waves present before each QRS and there's a QRS after each P wave. So we know this is a sinus arrhythmia. If we take a look at the numbers, we can see that the PR interval and QRS duration are within normal parameters, as is the QTC. However, we can see some ST depression in leads 1, 2 and AVL, but in particular the precordial leads from V3 through to V6. We can also see that lead AVR is raised by more than 0.5 mm. What we don't have though is ST elevation that meets STEMI criteria. So we have looked at the measurements and intervals. Now what about the size and the shape of the T waves? We can see they are very large, symmetrical and peaked in the precordial leads. We can therefore say these are De Winter T waves based on the criteria of more than 1 mm ST depression in the precordial leads, tall peaked T waves in the same leads, and more than 0.5 mm of ST elevation in lead AVR. The T wave in lead 1 is also very large compared to the size of the QRS. Now let's put what we know together. We have a symptomatic patient with De Winter's T waves. There is also a loss of R waves from V1 to V4, and we have rightward axis, which can be caused by damage to the left ventricle from myocardial infarction. So could this be a STEMI equivalent with an LAD occlusion? Well, the answer is yes. And here we have pictures of the patient's angio from the cath lab, also courtesy of Alex Beckett. You can see the one on the left with the catheter in the blocked left anterior descending, and the one on the right showing the artery now open. Here are two more examples of ECGs with the De Winter T waves. They both clearly meet the STEMI criteria, and credit for these go to Kelly Taylor and Madeline Hurd, but you can see the ST depression with symmetrical peaked T waves in the precordial leads and the ST elevation in AVR from the numbers at the right hand side of the rhythm strips. So now you know about De Winter's T waves. By activating the cath lab you may just save that person's life. I will finish this short video then by saying thank you for watching. Hopefully you find these short videos both helpful and easy to understand. Goodbye for now. Hope to see you all again soon.